complaint of poor stream from last 2 months, sir. Patient underwent laparotomy in 2017, followed by Jordan's myoplasty for navicular fossa stricture in 2018, and now he is presented with this chief complaint of this obstructive flow from 2 months only. And all investigations and were done, sir. Sir, the MCU was done, RGU was not done at that time, and MCU is showing a stricture at the just distal to this proximal, just distal to the pinoscrotal junction, and cystoscopy was done. On cystoscopy, scope was not negotiable behind mid-penile region. So today we were going to discuss about the management part.
Okay. So can we open the MCU, please?
MCU picture, please.
Good morning. Who is discussing?
I am Dr. Lalit from Kalyani Kidney Care.
Oh, okay.
Is that Prabhu?
Yeah, yes.
Prabhu?
Ah.
No, Manish. Okay, go ahead. Go ahead. You take the discussion forward.
Yeah, you want to describe this?
The management, sir.
Okay.
You know, we said show the MCU. Dr. Manish asked you to show the MCU. Put up the MCU.
So are you seeing the cystogram?
No.
Okay.
No, sir.
Now, sir?
Yeah.
Okay.
Sir, in this histogram, the bony architecture appears to be normal.
So we had discussed all this last time.
Yes, we have
Okay.
discussed.
Can anybody recollect what are the things about the micturating films that were commented upon? Let's see how much you took back.
Micturating picture, please.
There were a few observations about this. Do you recollect what the observations were? Not the findings in
Yes.
general.
Sir, in this MCU,
Yep.
bladder outline is normal and there is no reflex. Neck is wide open and
No,
posterior.
not findings. There were some observations about the MCU itself, about the technique. You were there last week, isn't it? Were you with us last week?
Yes, sir, I was.
You were. So some things were pointed out about how to do the MCU. Do you recollect?
Yes, sir. First of all, we have taken only one film lateral. We need 2 or 3 films lateral and this frog leg position also MCU. That would be
I'm
better.
sorry to be going back to this, but I think when observations are made here, it's good for you to go back, recollect, read, and come back the next time. The first thing that was said was a plain film is necessary. Correct?
Yes,
Second thing that was said was adequate opacification of the bladder and the stream of urine is necessary. The third was that the positioning should be oblique so that there is no overlap of the urethra on any bone, which will prevent us from delineating the urethra effectively, right? And fourth observation was that we should keep the penile urethra straightened.
Yes, sir.
Okay, Prabhu, you can take over.
So if the MCU is showing these findings,
Yes, sir.
what are you satisfied and discuss the management with the patient, or you still don't know certain things?
Certain things we still don't know. We don't know the length of the exact stricture and the associated spongiofibrosis detail we did not know from the only MCU. And so we need to do MCU with RGU or cystoscopy can be done, sir.
See, RGU is not possible. RGU was not possible because the meatus was not allowing any small size catheter.
Actually, sir, cystoscopy was done for this patient after this MCU, and on this cystoscopy, cystoscope was able to negotiate till mid-penile region, and after that, it was not able to pass.
So ideally, if you are planning it, you would plan a cystoscopy followed by MCU, or what would be your timelines? And let us say, let us say the patient has undergone cystoscopy. Then when you will plan an MCU?
After cystoscopy, sir.
Yeah, let us say the two patients. One, he has come with poor flow, and you're planning RGU, MCU, and then cystoscopy proceed. And the second patient who has just undergone a cystoscopy and come to you, not undergone a MCU. This cystoscopy means they have done all this dilatation and all that.
So the exact duration, I don't know at what time we should do MCU and RGU. Sorry.
Yeah, let's say the patient has undergone a dilatation today, then you will not do an MCU immediately after that, because you will find that the urethra is well dilated and your plan of surgical reconstruction may change because the urethra looks all right. So ideally, if the urethra has been manipulated, dilated, then you want it to narrow, to know the extent of the reconstruction you want to do. So if you go by textbook, it says 3 months. That's the time. If any dilatation or anything has taken place, then you allow it to narrow down and then do a MCU. So that the extent to which you are going to repair, or the complete extent will be a little bit more clear. So if there was a normal meatus, you definitely an RGU could have been done. So that would have answered your question about the distal extent of the narrowing. I don't know why it was not done. Whose case is this?
Vedanyagam Hospital.
Okay, they are still not online? Yes. Okay, so what do you want to do now? Let's say RGU is not there. We don't have any information. So for looking at the images and the cystoscopy, it is what? It is a
stricture starting from mid-penile till just distal to the pinoscrotum, around 3 or 4 centimeters.
So what you would like to do in this patient?
I would like to do substitutional urethroplasty, sir.
Before we proceed, I have one suggestion here for residents especially. If you cannot pass a 12 French catheter, please do not attempt to pass a ureteroscope or a smaller cystoscope. You will damage the scope. right? These are very thin stemmed, and when you try to manipulate this through a strictured urethra or try to take the bulbar curve through a strictured urethra, the cystoscopes get damaged, the telescopes get damaged. Don't do that. If a 12 French does not go, then think of other ways of evaluating the urethra. Come back, you might want to do an RGU, but don't proceed with an endoscope.
So the patient is asking, why not do a VIU? What is your comment on that?
Sir, first of all, the stricture length is big, sir. It's around 3 to 4 centimeters, and it's in the penile region. And patient is young, and VIU, there are chances of, in the penile region, usually we don't do, there are chances of ED. So,
chances of?
Erectile dysfunctions.
What would be your ideal indications for VIU?
Sir, stricture, epithelial stricture without spongiofibrosis or minimal spongiofibrosis of length around 1.5, less than 2 centimeters, sir, in the bulbar region, and in the penile region, it should be, we usually don't do for the penile stricture, sir.
Is that complete, the indications? You said, I'll repeat what you said, bulbar stricture, 1.5 to 2 centimeters.
Without spongiofibrosis.
See, all strictures have spongiofibrosis. There is no stricture if there is no spongiofibrosis.
With minimal spongiofibrosis.
Okay, then anything more? It should be a first time stricture, right? You are not doing it a third time, second time and all that. If it recurs after one VIU, you would ideally consider some other reconstruction. So first time procedure. Or you have done some reconstructive procedure and there is one area of annular ring which is causing trouble. So post reconstruction, if there is one area of narrowing, that is also one indication. You can still do one VIU. But definitely not for a penile stricture. So we'll agree with your point that you are planning a penile substitution urethroplasty. So what are your options in the substitution urethroplasty?
Sir, Bar-Bagley repair, sir, in which we'll do dorsal urethrotomy with BMG graft.
Okay, any other options? Any other options? Let us say the patient is a heavy smoker and it's a tobacco chewer and it is unhealthy, or there are changes of oral submucosal fibrosis.
We can opt for other grafts, sir, like bladder mucosa or rectal mucosa or lingual also we can take, sir.
What is the third one you said? Bladder, rectal and?
Bladder, rectal and lingual, sir.
Lingual. No, anything, see, it's very rare to use a bladder and the rectal. Before that, any other option you have?
Penile skin or inner prepucial skin.
Yeah, what is the important prerequisite if you are planning to use a penile skin?
That should be without hair, sir, and there should be skin should be healthy. There should be no history of presence of lichen sclerosis over the skin.
Yeah, basically there should be no lichen sclerosis. So this case very unlikely, because in lichen sclerosis usually the meatus is affected. Here it is somewhat the penoscrotal area probably is the affected area. So if you are planning penile flaps, what are the options? What do you name? Can you name the procedures if you know?
Sir, there are penile flaps, sir, O&D penile flap. In that O&D, we use longitudinal ventral skin island. And one is Jordan, sir. Jordan is also ventral flap. In Jordan also, we use longitudinal ventral flap, ventral penile flap.
Okay. Any other horizontal? You are talking of longitudinal. Any circular or transverse, whatever you like to call it?
Mechanic is circular flap, sir.
Huh?
Mechanic.
Mechanic flap. So normally when you take the skin grafts, where do you put it? Ventral, dorsal, what is your choice?
The skin graft, if dorsal penile still is redundant, then we use this dorsal graft, and if ventral is redundant, then we use ventral skin graft. So we used to place graft over the urethra and reconstruct.
No, it can be placed both dorsal as well as ventral, but many people keep it on the ventral aspect because it is easier to keep it, and there is no vascular compromise if you keep it ventrally. So coming to the buccal graft, what are the options in penile stricture?
What are the options for buccal graft?
Yeah.
So we can use skin, penile skin, diffusal skin.
No. Buccal graft only. You will like to place it dorsally, correct? You said Babagli technique. So how do you access that area? Means what incision I will have to plan?
We will take a longitudinal incision over the perineum. We will open, and bulbospongiaceous muscle we will divide. We will incise the buccal fascia and corpus spongiosum. We will mobilize, and after mobilization, we will give longitudinal incision in the dorsal area of the urethra, and we will open the stricture part, and then we will place this buccal mucosal graft over the corpus.
Dr. Prabhu's question was, where will you incise the urethra? You incise it over the stricture, but with respect to the clock phase, where will you incise it and why?
12 o'clock, sir. 12 o'clock we will incise it over the stricture areas.
How do you know the proximal and distal extent when I am cutting the urethra?
Sir, we can do cystoscopy, and we can put a catheter, and we can assess the length of this stricture, proximal distal end of the stricture. And
so when you have invaginated the urethra, you want to put a scope at that time, and you want to cut to the light?
That also we can do, sir.
Is that what you practice?
Don't get confused here. We are talking about strictures at the bulbomembranous junction, bulbar urethra. In that location, you can't introduce an antegrade cystoscope and cut against light. If at all you use a flexible cystoscope, you'll be losing a lot of money, right? The question is, we have to open healthy urethra, proximally, healthy urethra distally. Dr. Prabhu wants to know, how do you identify that this is the place to open? And well, we have opened as much as we need to open.
So these patients are on SPC mostly. So
no, this patient is not on SPC. Did they tell any time that he's on SPC? No.
You're getting a little confused. We are not talking here about pelvic fracture strictures. This, as we discussed last time, is most likely a iatrogenic stricture due to catheterization.
Yes, sir.
Okay, so there's no SPC.
So we can put a catheter, and we can assess the length of the catheter that is passing inside the penile urethra, and we can make a area, we can mark the area by this length and we can open from that area. And second thing, we can palpate the stricture area also sometimes. It's associated with spongiofibrosis and we can cut through that area.
Before you start the dissection or not, you would like to keep something across the urethra into the bladder, or you directly start
Guide wires.
Yeah, you should ideally keep a guide wire with the ureteric catheter, or sometimes even just a guide wire is good enough. If you don't, you may go and incise the dorsal wall and then ventral wall, and you will cut unnecessary tissues. So it's always better to have something across the lumen. Right. So my question was distal extent. How do you identify? You can pass a Foley catheter, ideally 18 size or something like that. So when you are making an incision, you should go some distance into the healthy urethra. So what is the length of the healthy urethra you should incise?
1 to 1.5 both sides.
Yeah, you should put graft on, you should go to the healthy urethra, open that and then put it on both the sides. So it's around 1 or 2 centimeters. Earlier they used to say 1, now 1.5 to 2 centimeters into the healthy urethra on both the sides. So if the stricture is 2 centimeters, you will have to take 4 to 5 centimeter graft. And you cannot put a 2 centimeter graft in that area because you have to suture it. So usually minimum graft is usually 4 to 5 centimeters. Suppose that area is very dense, you cannot access it from the dorsal aspect. So I believe you do one side mobilization, correct? This at the affected area, you mobilize on one side, that is on the patient's left side if you are a right-handed surgeon. Then let's say there is dense fibrosis, you are not able to get the plane, or I will put it other way, he has undergone several VIUs, there is severe spongiofibrosis, adhesions between the cavernosa and the spongiosum. So you are unable to get the plane on the dorsal aspect. So what is your next option in that case?
Sir, if there are dense spongiofibrosis, so better we should resect that whole area.
Resect? What is resect?
Resect
next to the spongiosum is the cavernosum. If you try to resect, then you'll be entering the corpus cavernosum on one side or the other, perhaps on both sides, causing problem on the table, causing problem later. That's why this is not a situation, again, like a post-traumatic posterior urethral stricture where you have to excise the fibrosis. Fibrosis here has anchored the urethra to the cavernosa on either side. So how will you open the urethra? What are the options available to you?
We can
you can't do it.
Open it.
Go on, please.
Ventral, sir. Ventral urethrotomy. Spongiosum we will cut and ventral, you will enter from the ventral side, sir. And on this dorsal, we can cut open the dorsal side also. And we can either do dorsal only or we can do dorsal only, sir. And
so what is it is in the name of any surgeon? Asopa technique, yeah. So if there is severe spongio, you are unable to get a plane dorsally. So can I, let's say there is one area of very narrow urethral plate where even just the guide wire is going or not going. So can I go and excise that segment of stricture? What is your thought on that?
Yes, sir. We can excise that part of the stricture, sir. And,
this particular area, that is it somewhere around the pinoscrotal or the proximal penile part. Can I go and excise and do an end-to-end anastomosis?
Yes, sir.
Be careful when you answer the question. Be careful when you answer that question.
Yes, sir. We can do dorsally. We can place the graft, and ventrally we can do end-to-end anastomosis. if it's short segment.
See, the classical excision and primary anastomosis, what you call end-to-end, is done only in the bulbar region because bulbar urethra is elastic and you can do all. But in penile, if I do that, what is going to happen? Why they do not advocate end-to-end in the penile part?
There will be buckling in the pendulous in the penis.
What is that?
Buckling or some deviation will be there.
Not buckling, man. It's not buckling. Don't confuse skin flaps in the penile urethra and hypospadia strictures with the question that Dr. Prabhu is asking. This is, he's asking a very straight question. It's not called buckling. This part of the urethra is not elastic, no? So what will happen?
There will be tension in the anastomosis.
Tension in the anastomosis? No, I can mobilize and get no tension. What will happen?
Very small segment, less than 1 centimeter, we can do with we can go for end-to-end anastomosis. But if segment,
no. When you have a segment of urethra in an area which is not elastic, if you try to mobilize it, you will cause CODI, isn't it? The penis will bend.
Yes, sir.
Then how can you answer that question saying that I will do end-to-end anastomosis when Prabhu said the only part that can have that liberty is the bulbar urethra? Any other place, you will have to use either some inlay, onlay, flaps, etc. so that you don't produce CODI. Remember that. Anything beyond the, distal to the penoscrotal junction is a dicey area. And you have to be careful about it.
Yes.
You also need to remember that if you are using any skin flap, which is the commonest skin flap that is used in the penile urethra, considering that we have a stricture in that area here? Which is the
Jordan.
What is the commonest type of skin flap that is used in the
Jordan flaps.
Jordan is not for this. Look at the length of the stricture. Jordan is for a very specific location.
Jordan, one is at navicular fossa stricture, and
I am asking, look at this stricture, this sort of stricture. If you have a stricture of the fossa navicularis or meatus, then yes, Jordan flap is good. It's a very good flap. What is the advantage of the Jordan flap over the Landy flap? Going back to the question, what is the problem of using, what type of skin flap should you use for this stricture? What type of skin flap should you use for this stricture? Have you heard of Orandi?
yes, sir, Orandi I heard, sir.
You heard of Orandi, right? So the Orandi flap is used for this. What is the limitation? What is the limitation of the Orandi flap if it is used for this situation? What is the difference between scrotal skin and penile skin?
Scrotal.
In terms of its looks. Shall we say in terms of its looks?
Scrotal skin has more hair, sir. Penile scrotal skin has hair, sir.
Scrotal skin has hair, and penile skin has no hair. So where does this hairline stop actually?
Just distal to penoscrotal junction, this hairline.
Yes, it's at the penoscrotal junction. So if you have a stricture and you're planning to put an Orandi flap, it will fall short if the stricture is more proximal than the penoscrotal junction. Because then you will have to get the skin flap into the scrotal skin, and that scrotum is going to be unhealthy because it will have hair. So the Orandi flap is used specifically for penile urethral strictures, starting even from the meatus right up to just distal to the penoscrotal junction, so that you have an adequate flap which does not cause any tension on the penis itself. Okay. So you know there are a few things like this that you have to remember. So you understood the question that Prabhu asked you?
Yes, sir.
Yeah. So these are important considerations when you are making decisions, operative decisions on patients who've got this sort of problem. And Dr. Prabhu mentioned something about having a guide inside. It's very important. It's extremely important to have something inside that urethra because it is very easy to lose the lumen. There's so much of dense adhesions, you will be cutting from spongiosal urethra into the cavernosal tissue because of so much of fibrosis. And you may suddenly find there's a lot of bleeding because you've entered the cavernosal tissue. And you will never be able to find that. So you have to be extremely careful. You must have a guide inside in the urethra, either a guide wire or ureteric catheter, right all the way into the bladder. If you just leave it in there, it will flop, it will come out. Better to stabilize it, just like you put these PCN guide wires, PCN guide wires.
Lalit, if I have, let us say, transected that distal penoscrotal area, how does the supply to the distal urethra come from when I have transected? This is just theory. I mean, we agreed that we won't do it, but for discussion's sake.
There are bilateral and dual blood supply for the penile region. So the dorsally, there is a dorsal penile artery that is supplying till the spongiosum part, and ventral surface, bulbourethral, two bulbourethral arteries are coming, and they are also supplying. So they are both are anastomosing at the glans area. So
No. I have transected the penoscrotal junction. So, see, let us say the antegrade flow is gone. Once I transected the antegrade, whatever you said, bulbourethral artery is gone. So, how does my distal urethra get its supply?
From the dorsal penile arteries.
Can you explain how it happens?
Retrograde flow, sir. Dorsal penile artery, it will be communicating with this bulbourethral artery at the glans region, and from there, this blood will retrogradely come to that area.
No, I am not happy with the answer. How does the dorsal penile artery supply the distal penile, the penile urethra? What is the course?
It is going till this glans area, sir, dorsal penile artery. And here it is arterizing with this bulbourethral artery.
Bulbourethral artery, I said, no, I have transected. You won't get that bulbourethral artery supplying the entire penile urethra.
So, retrograde flow, it can come from this distal part of this bulbourethral artery after the transaction.
Most exactly how it is coming. You answered that, but he is not happy with your answer. Because you haven't told him exactly what the communication is.
What are the anastomoses around the penile urethra, which will feed the penile urethra to the dorsal arch?
Sir, I don't know, sir, exact.
There has to be some anastomosis, isn't it?
There are some anastomosis in the glans, sir. I don't know.
Your head is in a spiral now.
So when you are doing some reconstruction, the
Can I
main...
ask a question?
Sir.
Can you separate the urethra and the glands from the two corporal cylinders? Can you separate them completely?
Yes, sir.
Yes. What is that operation that does that? Have you heard of Mitchell procedure for ectopia vesicae? Complete penile disassembly, they call it. You can separate the two corporal cylinders completely, and you can have the urethra with the glands nicely. So the glands cap, because the glands is part of the urethra, and the two corporal cylinders get adherent into that. So this dorsal penile artery, as it comes in, and you can separate it, but you find a lot of arborization between the corporal cylinders and the glands cap. And through that, it will come retrograde flow through the glans penis spongiosum, and that hopefully supplies the urethra. You can't go on and on relying on this supply for years to come. And this could be one reason why you have bulbar necrosis in patients who have extensive surgeries for this sort of condition. Of course, there is a component of infection added to this sort of a procedure sometimes, and that aids and abets bulbar necrosis.
The small supplies do come from the cavernosa, like when you are separating they're called perforating vessels. They're of course not enough to keep the penile urethra, adequate supply, but there are small vessels which supply from the cavernosa to the spongiosum. When you're dissecting, mobilizing dorsally, you can see some spurts of vessels will come. And then there are lateral supply, which is actually the branches of the dorsal penile artery. They give lateral branches, which again come and supply the penile. These are three. The major, of course, you mentioned, is the main dorsal artery entering the glands and then coming retrograde.
Yes.
When will you do? Can I do a ventral onlay if it was involving just the distal bulbar? What is your indication for doing a ventral onlay?
Sir, we can do both, sir, ventral and dorsal. Dorsal results are in comparing to ventral are good.
No, I'm not asking that. What is if there is a stricture at which location you will think of doing a ventral onlay? What are the indications for doing a ventral onlay?
The ventral onlay is mostly done for proximal urethral strictures, where we can easily separate this.
One answer you already asked, because the question was already there and you mentioned it. Prabhu asked you that question some time back. You're not able to separate, you're going inside wrong planes. So you do ventral. So multiple procedures. Apart from that, are there other indications where you would preferentially do a ventral onlay procedure?
You must be knowing the complications of a ventral onlay procedure. So when we do a ventral onlay, we would like that to be used only in a situation where some of the complications can be avoided. Ballooning, necrosis, bowing of the penile urethra, all this can be avoided. So think of that. It's an anatomical answer.
Supposing somebody has already had a dorsal onlay and that has failed.
Yes, sir.
That would be one indication where you would like to do a ventral onlay for that patient. So you have a second reason. Any other indication where preferentially you would do a ventral onlay? Have you heard of post-TURP strictures?
Yes, sir.
Yes. In the post-TURP stricture situation, you would preferentially do a ventral onlay simply because you don't want to dissect that area at the level of the dorsal urethra, because it is very close to the sphincter there. The sphincter is very thick anteriorly. You don't want to be going into that region. So you would do a ventral onlay there. All right?
Yes.
So
What is the difference between the ventral and dorsal onlay as far as technicality is concerned? Which is easier, which is difficult?
In ventral only, we have to cut this spongiosum also to reach the urethra. So after that, we have to do spongioplasty also. And in
he asked you
ventral only, easy. I think ventral is easy, sir.
Yeah, ventral is easy. Ventral is much easier procedure. But what could be the problem with the ventral procedure? While it is easier, can you encounter any difficulties with the ventral onlay?
Bleeding, sir.
Bleeding? Sure, of course it will bleed, but it's not exsanguinating because of that. Because you're cutting spongiosum, you bleed. Have you seen urethras where they have done multiple procedures on them? You open the ventral urethra, you are not able to wrap the spongiosum around it because there's so much of spongiofibrosis. So this operation is good where somebody's never had a procedure done, where the spongiosum is still supple enough for it to be approximated over the buccal graft to prevent ventral herniation or diverticulation.
Yes,
One of the drawbacks of the ventral operation, which cannot be used, ad nauseum on any situation. You've got to be very careful of what would be the most appropriate operation in this situation.
Who first described the ventral onlay?
I don't know.
The dorsal, I think you know. Who described? Barber.
Ventral was described by a guy called Jack Kennedy in University USC. And many people preferentially do that operation. In fact, quite a lot of the German authors do that as the primary operation because it's quite straightforward. And the results between the dorsal and the ventral, there's nothing much to compare. Equally, they've said that both are equal results. So, you can choose what you want, but you must be careful in situations as to which are out of the box, which are out of the ordinary. Then you have to be thinking as to which would be the most appropriate operation. Supposing Prabhu alluded to this fact that if you have very narrow lumen, in that situation, even a ventral graft will not be sufficient. You may have to open the urethra widely enough so that you put a dorsal inlay and a ventral onlay.
What do you call that technique, Lalit?
But with dorsal inlay and ventral onlay, tubularization.
No.
It goes by somebody's name.
Double facet, sir, pulmonary.
Pulmonary, right. Double face graft. Yes. Standard terms that are used and one should be able to understand what they mean. There's a lot of confusion between inlay, onlay, double face. Just remember what they are, that's all.
If you have answered all the questions, then one Mansoor technique. What is Mansoor technique?
In Mansoor technique, we were not using this BMG graft. We were directly cut open the urethra and we were taking sutures with this triangular or corporal cavernosa to the urethral margins.
Yeah, correct.
I got an X-ray from a doctor in Senegal yesterday was had the monster, you just asked this question, and therefore who had problems with his urethra after his laminectomy. They inflated the urethral catheter in the balloon in the urethra and then tried to yank it out, and he got a stricture. So he had a failed procedure, and then they did a monsieur technique for him, and that seems also to have failed. So you mentioned monsieur technique, so I remember this fellow who just by chance mailed me yesterday.
What are the chances of having erectile dysfunction in a patient who has undergone a urethroplasty? Patient is now, I think, 25, is unmarried. He's asking you this question.
Exact percentage, I don't remember, sir.
No, when you ask a question like this, you must remember what could be the reasons for somebody having ED after a urethroplasty, and for what condition is that urethroplasty being done. And accordingly, the incidence of ED will be different. If a patient with PFUDD has a urethroplasty versus somebody who's had a BMG urethroplasty, these are all operations of the urethra. And the question is a wide question, and it's a typical exam question. I would be surprised if Prabhu is going to set that up for you next week. If he does, then we leave it so that they can find the answer.
I will read.
You have done a good surgery. The patient comes back with the post-void dribble. How do you explain? How do you manage? How many people have this problem after dorsal onlay?
Post-void dribble mostly it occurs in ventral only, and dorsal only chances of post-void dribbling are less, but somehow it is possible in dorsal only also, because
how do you manage?
We'll ask the patient to wait for some minutes after maturating so that all the urine comes.
It's always possible to wait for something else. Patient can still get embarrassed by the drops of urine which might leak out. So he wants to know whether you can suggest some ways in which he can empty that urine before he leaves the bathroom.
He's a Muslim, he's very embarrassed.
Very good question. Very good question. The patient is a Muslim. He can't go for namaz.
He can release the urethra and try to.
Sorry?
He can manually press and squeeze the urethra from distal, proximal to distally, so that the remaining urine that is collected in that anastomotic area, this BMG area, can come out, sir. And we can
use the word squeeze. Any better word?
What does the milkman do to the udders of the cow?
Milking, sir.
What's the other trick you can employ if it doesn't work, especially in patients of the Muslim faith? It's a very serious problem for them, because every time they bend down and recite the Quran, 2 drops of urine come, they have to stop, they have to go and wash, come back. It's a big drama. It's a serious problem. So what is the best advice you can give them? The best advice is don't pass urine before your namaz. You know your namaz times. Don't pass urine. The problem arises after you pass urine. It's a very useful trick to employ in these group of patients. who are obsessed by this. And only when you see patients who are obsessed by this will you realize that it is very disconcerting for them. So I advise them, don't pass urine. You can finish your namaz and then pass. All you have to do is wash yourself, isn't it?
No, I have seen them, using tissue paper. They are very particular about the urine leak.
Normal fellows. Even the normal guys, there is tissue paper in the mosque available because there are old people there who have prostatic enlargement, who have post-nick dribbling, and they will actually wipe the glands with the tissue paper 2 or 3 times and then only go for namaz. So it's all very variable, but it's a very disconcerting complication of this operation. Even when you tell the patient, 2 years later, he'll come back and tell you that this problem is happening. So you must warn them before the operation that this is what you will have to do. The other complication that patients forget, in my book is mucus in the urine after an augmentation. You tell them, they'll forget it completely. I've never seen any patient remember it. After 2 years, after 1 year, they'll come. Or even after 6 months, they'll come and tell anybody who's had a bowel substitution, they'll say, Allah, white is coming in the urine. Thick thing is coming. So, anyway.
So if you follow up this patient, how many years you think he will be stricture free? And why there is a chance of recurrence after these surgeries? He's now only 25. You have done this surgery now. So will he be all right for the next 50 years?
So the results are the result of this dorsal only are stricture free are 90% approx, sir. 85 to 90%.
At what year? At what years of follow-up you are talking about?
Up to 3 years.
Dr. Prabhu says this fellow is only 25. What will happen when he's 50? He's not bothered about when he's 27 or 28. For that, you have to do some literature reading, isn't it?
When was the first urethroplasty using buccal graft described?
1996.
Yeah. So as such, you have only follow-up about 25 years. So usually the results are described, if it's a good paper, we say 5-year follow-up is the minimum requirement to say it is a success. But what if I follow up this patient 10, 15, 20 years, what is going to happen? Will it be stable? I mean, there won't be any problems as the time goes?
There would be some, sir.
For that, you have to read Tony Mundy and Wen's article. We have followed up 5 years, 10 years, and 15 years, different types of procedures, different types of etiologies for strictures. That's the only study that has gone up to 15 years that is worth noting. All the others are just, temporary, 6 months, 2 years, all that. All that works. 6 months, every one of these BMGs are okay, 100%. But what is important is what happens after 5 or 10 years, after 15 years.
So if I have a patient who has undergone end-to-end urethroplasty and a patient who has undergone buccal graft urethroplasty, how long should I follow each of these patients?
Up to 3 years, sir, minimum.
Which patient should I follow 3 years? Which patient I have to follow?
After end-to-end, there are no stricture till 3 years. So the patient will be more likely to be stricture free later also. For this DMG, sir, I'm not sure.
What is the purpose of follow-up? If you look at that, then you get an answer to your question. See, if he develops a stricture again, he'll anyway come back to you. But a follow-up that you're asking him to come for is meant to look for things which the patient himself might not be aware of.
On follow-up, we will check uroflow, sir. If uroflow is less than 15, so there are chances of recurrence of the stricture.
That's going to be debatable again. Okay, you can set a benchmark. You can say this is where, this is what, but the patient might turn around and say, why everything is all right? Why do you want me to undergo something else? What is it you're interested in looking for on follow-up? Like I said, the stricture, if it recurs, will present itself. You don't have to keep doing calibrations on follow-up to determine and then intervene. The patient has had it earlier. He knows when the stream becomes weaker, when he's strained, that look, it's not easy. Particularly after a good result, patient will recognize that things are not working. But from your side, what are those consequences that you'll be interested in, which is why you're telling the patient to follow up? And in which type of urethroplasties is this follow-up important?
What is the basic difference between end-to-end and substitution urethroplasty?
Graft. We are using grafting.
No. The answer is in end-to-end, which is actually called as excision and primary anastomosis. Basically, you are excising all the bad tissue and you are suturing the healthy to healthy urethra. So there is no area which has spongy fiber. Everything is primary. It's a primary anastomosis. Whereas when you do a urethroplasty, substitution urethroplasty, the diseased urethra is still there. That spongiofibrosis is still there. So you have a urethra which is bad, which is going to give trouble over the period of years. And you have a graft which is going to narrow over a period of years. So both the graft contracts and the urethra which is remaining, you have put it, you just opened the urethra, but that urethra is not normal. That is also going to contract. Graft is also going to contract. So the longer the follow-up, you have more recurrences in cases of substitution urethroplasty. Whereas if you follow up these patients who have undergone a primary anastomosis, if you see them for 1 year, their flow is good, the chances are that they will never form a stricture again because you have done a primary anastomosis. There is no diseased urethra when you have done a anastomotic urethroplasty. You have done a primary anastomosis. Whereas this is something like a secondary. You are still leaving behind the bad urethra. Are you understanding? So the longer the follow-up, the more the chances of recurrence. If the patient has not come to you, doesn't mean you would have gone somewhere else also, which is very common. So you cannot say the patient has not turned back, my follow-up is, my results are very good. The usual tendency is they may go to the next person.
Always. Any idea how much is what is the percentage of graft contracture that we talk about? When you talk to counsel patients, you have to tell them about graft contracture. So what is the percentage? Any rough idea of the figure that is there in literature? The percentage of graft contracture, CMG.
20-30%.
Yes, it's about between 20 and 30%. So you have to warn them. And as Prabhu said, the worse the spongiofibrosis, the worse, because the graft will have to depend on blood supply for its survival. And if the blood supply is not good because of spongiofibrosis, it's not going to survive. To my mind, the DNB urethroplasty actually faults every tenet of surgical principles because it is suturing no like tissues. It is just similar, somewhat similar. In surgery, we are always taught like to like with nothing in between, isn't it? And that's why the EPA, as he talks about, gives good results. Mucosa and healthy tissue. Here, you've got something else in between. So it's bound to fail. So there will be some patients who will fail. And when you read Mundy's article, you will know what is the failure rate at over 15 years. I don't know, do you know if there's an article, any other article which has done this sort of a follow-up for 15 years? I don't remember any article that, even in the recent times, where even Stephen Brandeis and all these fellows who did work with mechanics and all that, they have not done very long-term follow-ups like this 15 years.
Stricture urethra has fallen off the radar, urethroplasty and strictures.
Right?
Strictures and urethroplasty has simply fallen off the radar. Nobody writes anymore about this.
We're only now more interested in malignancy at the moment, isn't it? It's that's a big thing. There's no doubt about it. There's so much advance taking place that everybody's concentrating on that.
Prabhu will report robotic urethroplasty.
Well, somebody's already presented it, so it's all right. Prabhu is late.
Sir, there's one good news. Anuj Dumra from Puttaparthi, sir.
Yes, he's got the gold medal.
He's got the gold medal. He was.
Somebody else who's got the gold medal from Puttaparthi.
Yes, sir.
Else?
No, sir.
My colleague sitting here in front in Veeranagam Hospital, when he was there with Dr. Sridhar, he got the gold medal in the DNB. Am I not right, Sridhar? Yes. So when in 2004, the second candidate from Puttaparthi was got, and Anuj is working in Sirsa now.
Yeah, Anuj Dumra is my senior, sir, from MS, sir. We did MS from same college.
He is working in Sirsa, in Haryana.
Yeah, his father's hospital, SK's hospital.
Very good. Then Fish has a Karthikeyan joint.
Today I didn't hear anybody.
Because he came in for our KVM session.
Oh, we are here.
Oh, yeah, right.
Yes, sir.
What
we have discussed is about non-transecting augmentation urethroplasties, one, and ejaculated dysfunction after substitution urethroplasty.
Sorry, sir. Can you repeat, sir?
Non-transecting augmentation urethroplasty. When do you do that? What is the indication for a non-transecting augmentation urethroplasty?
I don't.
Okay.
Read up. Read.
And what is the incidence of ejaculated dysfunction after substitution urethroplasty?
Sir, he has already told he doesn't know.
Pardon?
He has already answered that he doesn't know.
Okay.
This is now food for thought. Go back and read.
Thank you, sir.
Thanks.
Thank you.
Thanks, Manish. We'll catch up next week. Thank you all. Have a good weekend.